One of the questions we're all wondering is, where do we go next with EGFR inhibitors? How do we make these work better? What do we do with EGFR inhibitor failure? And the two approaches that are being developed is, one, make better EGFR drugs. Start from erlotinib, go to afatinib. Go from afatinib to the next third-generation drugs from Clovis and AstraZeneca. From there, fourth-generation drugs could be coming soon. The second approach is take these drugs, combine them with something else to make them better. Look for synergy in that direction. The combination approach so far has not met with a lot of tremendous successes. The one exception is combining an irreversible EGFR inhibitor like afatinib with an EGFR antibody like cetuximab. The problem with combinations is toxicity. And that the fact is, when you put these together, because each has different side effects, sometimes overlapping side effects, you may not be able to get both up to a dose where they're active. If you combine erlotinib with crizotinib, we've learned today at the conference that neither drug actually makes it to full dose because both have overlapping toxicities. I am wary of combinations, and I think the key to combinations is to get drugs that are mild. If the drugs have a broad therapeutic range where they can be given at a lower dose and still be effective, then you can combine them. If the drugs have a narrow therapeutic range where higher doses are toxic, where a lot of doses are toxic, but only the toxic dose is effective, you're going to have a hard time putting them together. I also think it's going to be hard to take these great new drugs, combinations or next generation inhibitors, and bring them early on and beat a drug like erlotinib, gefitinib, afatinib, because these drugs are so good. You know, so many patients respond. Their responses are so durable that beating these is going to require a really big, expensive trial with a lot of patients. I think we might be able to get there. But given how great these drugs are, I'm okay with focusing on the space of waiting till erlotinib fails and then adding drugs or switching drugs at that point. And so that's my favored place for exciting new developments. Once you have a drug that does fantastic stuff to people failing erlotinib, I think it's reasonable to try it out earlier on, but given how great erlotinib is, it's going to be a hard drug to beat. It may be that erlotinib with an immune therapy somehow is disease modifying and turns this into a curable disease. I mean, I would love to get to that point, but I want to have some really compelling data before I go there, because these are hard questions to ask. The easiest clinical endpoint for these trials is progression-free survival, and yet we've just discussed that resist progression isn't clinically that meaningful, because that progression, for a lot of patients, we just push them forward and continue on drug further. And so developing a trial that's going to be really transformative and informative is going to require a lot of thinking and a lot of investment. And I just want to have the data available before we go there.